Health systems, small or large, are essential to ensure the well-being of communities. When disasters, conflicts, crises, and pandemics hit the communities, they still need health systems. Functioning health systems can reduce deaths, injuries, diseases, and human suffering. However, such shocks and stresses do not spare health systems. What better example than the COVID-19 pandemic? Resilient health systems can cope with external shocks and stresses. Resilient health systems can bounce back, and resilient health systems can recover using their resources. To make our health systems resilient, we need to learn from each other. We need to share experiences, both of success and failure. We need to innovate, we need to collaborate. The International Journal of Health Systems Resilience is a platform to explore, share, discuss, debate, and innovate. International Journal of Health Systems Resilience is your journal.
So today we are going to launch the International Journal of Health System Resilience, and we are going to have this International Symposium on Health System Resilience. Actually, 2 years ago, in 2020, we started the International Journal of Community Resilience, where we wanted to create a platform on knowledge and practice on community resilience. And then one of my friends, Dr. Susantha, sent an article and we published it in the journal, but then he kept on sending many articles. So I found that, okay, now this is really going beyond the scope of our journal. So probably we need to have a special journal for that, because it is part of resilience, but we wanted to make it go beyond that. So that is how the whole thing came in, and we are right on track on this topic due to different things that's happening around us. But we are going to talk about resilience and how we could adapt to different shocks and stressors. But I don't want to bore all of your evening with resilience and disasters and emergencies. So we want to give you a very warm welcome to Sri Lanka, as if it was in person. So this is a small cultural performance from Sri Lanka. I hope we will be able to do that in person in years to come. For the moment, enjoy this.
Guru music, Catherine. Piano, banjo, tambourine, mandolin. Violin, violin, looking gonna sing a violin. Viole, masana, solo viole. Viole, over my cat, baby. Oh, baby, nada me dale. Nalave, nada me totile. Viole, over my mangargie. Sangita, sastra, kumariye. We know they over there, sureliange. Viole, viole, mage. Viole, viole, mage. Mannaram pitivalle madakiyavallon chille konne kadan adakadan sindu kiyande kundumani kundumani oh kundumani kundumani oh kundumani nahay karabude kane kadu kangamasiyola mottak kiliyen nadakota vasaidalama uludu kota talvela talbaka mat giniya vela kundumani kundumani oh kundumani kundumani oh kundumani.
As much as that performance is some pieces of music from Sri Lanka, from different traditions, from Sinhalese folk music to Tamil music to some music that was gifted to us by Portuguese, Dutch, and maybe British. The amazing thing that I find in this performance is it's performed by a group of young people from different nationalities and ethnicities, from different languages. So the language of health system resilience, or this dance of health system resilience, or the song of health system resilience has to be sung in all our languages, in all our places, in our all different health systems, because it's so important. We thank all our authors who took time to document and write and do the rigorous peer review process that we did to bring the articles to this status. And if you want to know more about the philosophy and what we want to do in this journal, please read the editorial that I wrote, and it will give more information. So I'm not going to introduce Brian Walker, but I invite him to introduce himself. He's one of my great teachers and mentors, who has been always behind me. And tsunami was such a bad incident, but because of tsunami, I met him. So I'm so grateful to have you, Brian Walker, here. And Brian, please enlighten us about what you want to tell about health system resilience using one slide. Over to you.
Okay, thank you for your introduction. I think it was very generous, Noville, to speak of me as your mentor, because we were colleagues together and there was mutual reciprocation in both directions. I learned as much from you, and I hope you might have learned a little from me. Now, I want to talk about this graph very briefly, because as you can see, it's a dramatic change in the human population which has taken place in our lifetime. In the 1930s, some ecologists began to be a bit concerned about the possible future of an expanding human population. By 1962, the Club of Rome hired the biggest computer in the world and produced some graphs of prognostications that they anticipated might happen. And one of them looked very much like this one. But we still need to account for the dramatic rise in recent years in population, and in particular, the increase in size of the elderly population. When I was a student, the average age of expectation of life of a Burmese woman was 37. And that has changed dramatically, because the two aspects of resilience came together 100 years or so ago and combined to allow people to live much longer. And as a consequence of increased education, increased understanding of health studies, the resilience of the culture in which we live, combined with the resilience and the bounce back of the human body as a consequence of education, vaccination, antibiotics and antivirals, pushed our population up enormously. And some diseases, such as polio, were almost entirely eradicated. But the combined resilience of the human individual and of the governmental system with its public health care and health systems has given rise to some other problems in addition to those that we are facing at the present time from the introduction of a range of viruses. And if I can just take one example to illustrate this, that of polio. Polio was almost entirely eradicated from the world. And that was a wonderful reflection of resilience. But parents started thinking, oh, there is no polio about, so we need not get our children vaccinated. And as a consequence, there was little or no protection for polio in many countries. And at the moment, in New York, there is a state of emergency declared because of a massive bounce back of polio and polio cases, including deaths. So we have to be careful with our resilience in ensuring that whilst it needs to be effective, we need to be able to counter the good side, which can lead to a bad side. The Chinese population encouraged a one baby per family system, but the huge increase in the elderly population means now that China has gone the other way. And we're trying to increase in some countries the range of children in families and the numbers of children in families in order to care for the elderly population, who are coming up with an increase in some diseases which we hardly heard mentioned 50 or 60 years ago. So the bounce back, the resilience is a wonderful thing. It's necessary and it's essential, but it can itself lead to other problems. Thank you.
Thank you so much, Brian. Thank you so much for taking us on a journey from a bird's eye view on what has been happening and how the resilience could be really a challenging issue to address even in the current day times. This is a suggestion by you and an invitation by me to document this as a paper in the journal so that we could expand on this and let people explore the concept more. Before we move on to the technical presentation, next one, I would like to invite Dr. Hemantha Herat. He's the National Coordinator of the Disaster Preparedness and Response Division of the Ministry of Health. And he is also the Deputy Director General, Education, Training and Research. It's a great honor to have you here. And I would like to invite Dr. Herat to say a few words at this inauguration.
Thank you, Noel, Brian, and all other colleagues who are friends who have joined you with Noel. It's gives me a pleasure and honor to have a word with you all at this moment, where this great occasion, where launching of this Journal of Health System Resilience. And as my colleague and my the partner at the disaster management process in Sri Lanka, I know that what you all are doing, Noel, especially what you are doing at this disaster preparedness unit is very little compared to what you do outside the disaster preparedness unit. So I know that there are many activities you have undertaken and you are doing it, and you have a very large audience of people who are with you, to support you, to share experience with you, and also to discuss matters related to health systems resilience. So you are an expert and a person born to discuss or address the issues related to disaster management and probably the community level especially. So therefore, I just want to congratulate you at this moment for launching this activity, and I know you have a very long way to go, and I wish you all the best for doing all these activities in relation to disaster management, which is a pet subject of me as well. So once again, thank you for inviting me this, and I wish all the very best and success in your endeavors, including this one, and in future all other endeavors. Thank you very much, and nice to see you. Thank you.
Thank you. Thank you so much, sir. Thank you very much. It's really a pleasure to have you here as a person who has always been with me in my journey so far in disasters and emergencies. And thank you so much for the opportunities given. Okay, with that, now let's move on to the first technical presentation. The technical presentation would be based on the papers that have been already submitted and published in the journal. So we are going to just discuss a little bit about the paper, but all these papers are available on the journal for you to read and refer further. So without much ado, I would like to invite Dr. Estela Gerati. Dr. Esti, as very fondly remembered by us, is the Chief Medical Officer at ESRI, Redlands, California, USA. And she will be speaking to us about geospatial technology for health system strengthening. So over to you, Dr. Esti.
Thank you so much, Nabil. Can you please verify that my screen is properly sharing?
Yes, we can see it, Dr. Esti.
Wonderful. Well, I have to say hello to everybody, and I'm very honored to have this opportunity to take part in the launch of the International Journal of Health Systems Resilience. I think it is the perfect journal for the times and lots of good things to discuss. And it's also my honor to present this educational article that I worked on with our esteemed editor and founder of the journal, Novil. So let me go through and share with you what we did. If I can make my slides advance, there we go. Okay, I hope that most and maybe all of you recognize this map and perhaps the gentleman pictured. And if you don't, this is the Soho district in London in 1854. And all of those dark bars that you're seeing are deaths from cholera in a household. Now, the man pictured is Dr. John Snow. He was a physician at the time, and nobody knew what was causing cholera, but he went about solving the problem in a different way than others had before. And just to make it easier for you to see, he mapped all of the water pumps within the area. And one, as you can well see, seemed to have a lot of death from cholera around it. And so he alerted health officials. They took the handle off of that water pump, and that stopped the epidemic at the time. So he used geospatial technology to improve a major outbreak causing death in London at the time. So you might ask yourself, this is an iconic map. Just about everybody in health has seen it. Why didn't this catch on? Why have we not seen now over 100 years of geospatial technology for health as a predominant way of strengthening health systems? Well, I don't know, maybe it just wasn't time, but here's another iconic map that I know most of you have seen. This is the Johns Hopkins University dashboard for COVID-19. It was built in 8 hours by a graduate student. Of course, there was a lot more effort to maintain it. He's pictured in the circle. His name is En Sheng Dong. And he used geospatial technology, again, to solve an outbreak problem, or at least to bring situational awareness to the problem. Now, I think the time was right, and people started really catching on to some of the value of geospatial technology. So I will bring you to this quotation that I appreciate from Alice Hoffman, who said, "Once you know some things, you can't unknow them." Hundreds of billions of people have access to the Johns Hopkins University dashboard. We can't unknow what we've learned about the value of looking things from a geospatial perspective. It's a burden that we can never give away. So what can we do? How could geospatial technology, now that we know about it, be used for health system strengthening? And that's really the topic of our article. But in case you're not super familiar with geospatial technology, I just wanted to provide 2 slides to show you that taking a geographic approach is actually very helpful when it comes to solving problems beyond the pandemic, which is what we'll discuss, but it is a science-based approach. It is integrated with the other kinds of data, systems, and tools that you already have. And it's holistic because it considers not only your current operational issues, but also the context in which everything occurs, your built environment, social relationships, different kinds of environmental insults. And turns out maps and mapping is very understandable, and people can absorb quite a lot of information all at once. Now, a lot of people, when they think about the geographic approach, particularly as it's enabled by Geographic Information System Technology, or GIS, that this is mapping software. And of course it is. Maps are the center of what a GIS does. But it's so much more than that. And so I like to use this slide, especially in the context of what I'm going to explain about our paper, to share with you that a GIS has tools to address all of the common kinds of functionality issues that come up in workflows, from data collection, visualization of many types, including mapping, and analysis and modeling to understand root causes or predict the future. Now, once you've gotten beyond that, you get into some of the applied phases where GIS can also support, including planning interventions, designing communities, prioritizing decisions, or making pivots when the situation calls for it, as well as promoting action and evaluation of outcomes. So here's how we approached in the paper, which you should read for all the details, the idea of taking geospatial technology, particularly apps and solutions that already exist, and applying them to health system strengthening. I will warn you in advance, all of my graphics are very small. You'll have to read the paper to be able to really dig into them, but I will give you enough of an overview so that you can understand what's going on. So in the top left, we began with the World Health Organization's 6 health system building blocks as a way to start to understand what's necessary for health system strengthening. And those building blocks, so there are 6 building blocks, there are 4 outcome measures, which you see on the right, and in the middle, there are 4 kinds of attributes or characteristics that were considered desirable. Now, WHO didn't include resilience. We obviously thought that was very important, so we put it in purple on the bottom for our consideration for a final model. Then I'm going to move over to the right, and that entire half of the screen is really an update or an enhancement of the WHO health system strengthening building blocks, which includes the opportunities to monitor what's going on and evaluate the process. So it really puts a frame around the framework. But WHO did get some criticism, and may I say just suggestions for how they might approach this better. And we end up with the lower left-hand framework, which is about beyond the building blocks, I think is what they called it. This came from Sachs et al., and really was meant to be more inclusive of the idea of care outside of hospitals provided in homes or in communities, as well as an understanding of context and the social determinants of health. So what did we do? We combined all of it into a grand framework. Again, I'm not expecting you to read it, but we have organized by colors different sections of the matrix that we put together. There are 5 process building blocks, 6 input building blocks, 4 outputs, 5 impacts, and 1 goal, which is to optimize health for individuals and communities. I didn't even have room to put it all on the slide, but you can see it all in the final article. So with that in mind, what did we do? So our process was as follows. We began with existing solutions that came from Esri's ArcGIS platform. There were 149 pre-built applications and solutions that we reviewed for their relevance to health system strengthening. We came up with 63 that really could potentially be used in our model with all of the different indicators. Then we had a group of technical experts review those 63 apps, and they came back and they said, well, 3 of them were due to be deprecated, so we had to exclude them from the process. So we end up with 60 solutions and applications that were evaluated against our grand matrix. And then our review by technical experts was continued. And so we ended up with 5 of us that went through all 60 apps to see how they aligned with the various indicator domains. And then we validated our results. So this is our working spreadsheet where we all finally agreed, where in white, the left-hand column showing all of the 60 solutions and applications was plotted against every one of our indicator domains in the matrix. Okay, so again, you don't have to read any of this, but what I'm showing you is how that all came out. So on the left are the 60 different solutions, and we're indicating by the bar how many of the indicator domains in our framework they met. So you can see they were pretty helpful in meeting health system strengthening needs. And at the same time, if you just flip that on its head, we have the different indicator domains and how many solutions are actually supporting them. So however you like to look at it. The main point from this slide is that indeed, there are existing solutions and actually quite a few of them that can support health system strengthening from a geospatial perspective. And so we then broke down all of those different tools, the 60 different solutions and applications, to understand what was the underlying technology that was involved in all of them. And then we sorted those by their primary functionality. Some of them were data collection tools. Some of them are more for analysis and synthesis of the data once collected. And some of it was for communication and engagement. So this is how that all fell out. And then we applied that matrix to our framework to give an example of what it might look like as a health system is going through a workflow problem. So then we wanted to go through a workflow problem and see if this really is applicable. So 3 of the solutions that were already in existence were really focused on COVID-19. But we wanted to say, okay, well, could these be adapted and easily configured and used for a common health system problem? So in our scenario that we go through in the article, we talk about a health system that wants to address growing concerns over cardiovascular disease in the community. And then we applied the different solutions to that problem to see if it actually did work. And in fact, maybe we wouldn't be publishing it if it didn't work. So I leave you to read that scenario. We also do give a little bit more in-depth description of some of the tools that we found most applicable to health system strengthening from the ArcGIS tool set. And in conclusion of our work, we certainly did find that there are a large number of available geospatial tools. Nothing necessarily needs to be invented. They're ready to use and can support health system strengthening. So our recommendation is, of course, to read and understand the article because it puts the geospatial solutions into terminologies and a framework that should in many ways already be familiar to those in the field. So helping to become more actionable for health systems policymakers, planners, administrators, and others at all geographic levels of concern. And we also believe that resources should be allocated for enhancing geospatial information infrastructure and equipping health systems with what they need to start to take advantage of this technology. Because, of course, as Leonardo da Vinci said, he has been impressed with the urgency of doing, because knowing is not enough. I told you in the beginning that now that we know, we can't unknow that there's value in geospatial technology, but we have to apply. Otherwise, it's useless. So we can't be willing, we got to start doing. And my first advice is read the article, that will help. And we also wanted to just end by thanking our expert technical reviewers, Jared Schultz, Jeremiah Lindeman, and Jonathan Garita Leka for supporting and going through the process of reviewing all these applications. And Nabil, I'll turn it back over to you.
Thank you so much, Dr. Esti, for sharing those thoughts. We had a very big discussion before this paper. So we really want this to be an educational paper. We want everybody to learn and use these tools as and when needed. Are there any questions that the audience would like to ask, or shall we just move on to? No, Dr. Esti might have to leave, so we will have to take up the questions now. So if anybody wants to ask any questions, I have some questions, but if I would like to give the preference to the audience.
I think everybody's anxious to just read the paper.
Yeah, I think. Yeah. So Dr. Esti, I just wanted to ask this question, 2 questions actually. First one is like these tools could be overwhelming to a medical person. Most of our audience here are doctors, so some of them have some public health training, some are hospital physicians. What are the educational resources that people have if they want to learn more about spatial technology and use it for GIS in relation to health? And the second question is, the common question that we get about the affordability of these solutions. They could be expensive. And now we are going through a big financial crisis. Sri Lanka is going through a big financial crisis. So actually we are cutting down on very important things like, we think twice when we want to purchase a packet of paper for printing. So the crisis is that bad. So in this kind of a situation, can we still have space to use spatial technology for problems that we face? And, this could be really a challenging task for emergency managers. We have to bring all our skills, limited resources. So what do you think about those two questions?
They're great questions. Thank you, Nabil. I put something in the chat. Oh, good, I did spell it correctly. There are two educational resources that I'll offer. First, let me start by saying that previously, I used to tell people that we literally have thousands of free hours of training. But as you pointed out, Nabil, some of my health professional friends said, I don't want thousands of hours. I want to know what to do for my job and get it done quickly. So I have two resources that really fit the bill there. One is it's a book. It's called GIS Jumpstart for Health Professionals by Kristen Kurland. It's got 4 or 5 chapters and it runs through a tutorial really showing how can you get started quickly. The second one is a curriculum that I've built with a team at Esri that has approximately 35 to 37 hours of training materials, so roughly equivalent to a certificate type of program, where you get hands-on training in those tools that you and I discovered were most relevant for health system strengthening. So it's very focused training using health situations as scenarios to better understand what's going on. Now, let me quickly also address your question about the cost of the software. The first thing that I usually say is that in many ways, although I know that it's a bit different right now in Sri Lanka, cost is relative to value, right? We must look at anything that we purchase as to the value that it supports. And so those things need to be in balance. And I would never recommend anybody purchase software that is not doing something to save them time or money or improve health outcomes, make systems flow better, whatever the case. Even with that said, and my passion and belief that a GIS program will add value for any health system, we know there are financial constraints, and we never want to have somebody miss the opportunity to use the software because of money. So in the chat, I have put in our grant program, which offers 2 years of free software for ministries of health in countries that have lower resources, according to the UN. And then we have a discounted program following that for sustainability, provided that the Ministry of Health found value in using the software. They can continue the use of the software at a very deep discount. So we want everybody to be able to have what they need, because we know that health system strengthening is vital.
Thank you so much, Dr. Esti, for those questions and answers. And we could connect with the people who are involved in that in Sri Lanka. If any agency or any unit in the ministry is involved in that or interested in that. Any other questions that are relevant to Dr. Esti? Okay, so let me do a small change to the agenda. And now, thank you very much, Dr. Esti. And we will come, I'm sure you will have questions from the next presenter. So now I have the honor of getting to the podium, Dr. Lakshita Iroshan Ranasinghe. He's a registrar in community medicine from the Ministry of Health. He's going to talk again about a very related topic. So it's called the WP COVID, a web-based computer and mobile application for COVID-19 disease surveillance. So over to you, Dr. Lakshita.
Thank you. Thank you, Nabil, for the invite and accepting the paper. And this was written some time back, and I think you can
Yes.
see my screen.
Yes, please put it on
Okay.
full screen mode. Yeah, that's great. Now we can see.
So, I'm a registrar in community medicine attached to the Family Health Bureau. I did the writing part for this, planning part of this particular project, which was undertaken by a third party, which is private limited, which worked for the Western Province Department of Health in the Western Province. So I'm just here, a delivery boy, presenting somebody else's work, but I've been involving because I was asked to write about this project. Okay. So these are the people who were involved in this project. So I have to mention, show their details. So it started from the Western Province Governor and the Western Province Provincial Director, and the WHO was involved in as the technical lead, and it was undertaken by a technical partner called G-Century Private Limited, and they supervised and undertook all the technical GIS related mapping, software coding, and everything. So this was initiated when we were hit by the COVID first wave. And the problem was the Sri Lankan health system and the routine disease surveillance system had few bottlenecks to be addressed and to be geared to do disease surveillance in a situation like COVID. And just for the international audience to see the structure, health system structure here. And you see from the top hierarchy, it divides into two as the preventive and curative sectors. And here the MOH, the Medical Officer of Health, which is the primary public health providing institution in the periphery. We have about 355 MOHD offices all over the country. So this is the Western Province because this is initiated in the Western Province and which has the highest population in the country. And this is the routine disease surveillance system in Sri Lanka. It usually, the surveillance starts at the suspicion of disease at the hospital ward or by a GP. On suspicion, he sends this H54444 form to the Medical Officer of Health, and he sees it and he hands it over to his subordinate PHI, who is a public health inspector, and he does a field investigation. Following the field investigation, he is supposed to send a report back to the MOH, and the MOH sends it to the epidemiology unit, which is at the center, as well as one copy to the regional epidemiologist who is stationed at the district. So this was the surveillance system which we had to recreate or like convert into an electronic form with the help of geo information systems. So these were the problems we had. It was novel disease, so the natural history at the time of development of the system was unclear, and it was highly contagious. There was a lot of rumors, a lot of conspiracy theories of the emerging disease, and there was no proper vaccine available. There people were trying so many indigenous to Western medicine remedies to prevent the disease, and there was significant amount of mortality associated with it, and there was a public panicking, lockdown, and there was this big social disruption. And with that, there was some known data on the existing system which was a survey done by the epidemiology unit in Colombo, which said it takes average of 6 days for an MOH to receive a notification from an institution. And then after receiving, it takes average of 2 days to dispatch that form from the PHI. And overall, it takes average of 10 days taken by the PHI to complete the investigation. So the delay was so much that we could not wait for the routine surveillance system to cater to the requirement. Therefore, we had to develop this system with having with the objective of developing a common platform to analyze COVID-19, dengue, and other communicable diseases. Actually, it was meant for COVID-19, but later on it was adopted for dengue and other communicable diseases, and disaster situation for health professionals and public sector. And we have so many other specific objectives attached to this, but it was basically to address the bottlenecks of COVID-19. And we faced few challenges. These were the challenges. The epidemic surveillance system have been reporting, operating without the support of geo-reference databases, and advocating on new technology to the politicians and to the administrative hierarchy was a challenge. And the rest is discussed in the paper. And if I talk about the methodology, there were data inputs on your left side and the output on the right side. And we planned different methods at different levels. Like for the community, we gave a mobile application. For the PHI, who is the primary data collector at the field, he was given a PHI mobile application. And there was a plan to do a drone mapping, which was done as a pilot, but it was not continued. And in the hospitals, the desktop-based, the computer-based web application was given, and the community had a web application. All this data was processed at an automated warning system based on ArcGIS as well as QGIS. And from this server, the process information was given to the health professionals and to the community for awareness and for decision making. And this is how the data flow happened. You see from the center, the data flow happened through the periphery. And it has so many features, but I would like to highlight few things. There was a risk analysis window, and there was a fast tracking system for real-time recording of COVID-19. And the inbuilt system, there was an inbuilt research component for the health professionals to visualize data from the patient information. I mean, not the identification information, but the information related to disease conditions and the epidemiological data. And we had multiple data feed from different input as I showed earlier. And if I go a little more detail into the features, these are the screenshots taken from the app. And we could do patient clustering in the app. And then the clustered patient could be visualized on a geospatial map, as shown here. This is more of a summary map. And in the summary map, the health professionals were able to search a patient by name and identify the location of the patient. This is only meant for the health professionals and PHIs and their MOHs. And there was another window to identify the critical areas by the count of the patient. So it was like an MOH or a PHI could trace the number of cases in a given in a given geographical area and get an idea about how severe the infection spread was. And finally, we had patient distribution statistics. So every data could be summarized and could be presented in graphs or in tables. And there was another feature which allowed the epidemiologists or the health workers to compare disease situations. For an example, the situation of COVID situation of wave 1 could be compared with another situation at COVID wave 2. So that feature was also included. And finally, district summaries were presented like this, and it could be amalgamated to the country summary. And this was an example of the country situation when we were hit by the COVID wave 2. It shows the clustering has mostly happened in Colombo suburbs. And there was another feature added called the proximity analysis. There, an interested party could see how much are we affected locally by taking a radius, and we gave the cutoffs for like the case density, and they could get an idea of how severe the infection spread was. So these were the features, and everything has been included in the paper. And this is actually not a formal research per se. We did it as a project as a solution for the very bad situation that we faced during COVID wave 1 and 2. And it was highly valued by people during that time. And it's actually in the rankings, it was actually above Zoom cloud meetings, because before the Zoom cloud meetings became very popular. Suapeta, I mean, this mobile application was ranked above Zoom in Sri Lanka. And these were a few of the comments that we got from the community, and it had a Google rating of 4.1, which was considered very good. So it is open for discussion. Now I have to give a comment on the present situation. Presently, the system is running, and it can be accessed both by the public as well as by the healthcare providers. Now the COVID surveillance is not happening through the app because it was mostly meant for emergency situation. Now the app is geared to collect dengue related data. So thank you. Do you have any questions? I'm here to answer.
Thank you so much, Dr. Lakshita, for sharing that. So I know it became very popular during the COVID-19 period, and even during the National Emergency Operations Center for COVID-19 was much talked about. Yeah, and yes. So I have a question for you. Like, I know these tools are really good. How receptive are the public health professionals to accept them? Like, we are very much paper-based, and we always want to do contact tracing by telephone calls. And so how do you feel that, this map being, the application being used by the public health professionals? Do you see that they like it, or there's hesitancy?
I have my personal view on this. When there was a dire need, it was highly accepted by everybody, even those who did not like the computers much, who had been reluctant to use the web applications for other disease surveillance purposes, because this idea came even before we were hit by COVID. the people who were reluctant to use a system like that before COVID were actually, some of them were very positive of introducing this. However, I think for individual reasons, I have seen even among my colleagues, there were like very good epidemiologists and people, but they still believe that the majority of our people, like citizens, may feel a little difficult to access a system like this, get the best use. But I seriously doubt that, because when we practically implemented this, we saw the effect, and even like we couldn't really do a piloting because we were in such a hurry to do this and get the data to combat the epidemic. But my personal opinion is Sri Lankan population is technically sound enough to grab or to use a system like this, even the health professionals. But there are few people, few of my colleagues and people who are not very positive about it.
Yeah, thank you so much. That would be that is I think the same for many innovations. There's one question.
Lakshita?
Shita?
Yes,
Yeah.
Yes.
Lakshita, regarding this.
Susanta, we'll just go to the
yeah.
question in the chat and then we'll come to you. Okay. Give me a
Okay,
second. There's a question that Dr. Esti asked. Lakshita, you can have a look at it. I think for retrospective analysis of COVID as well as for dengue going forward, have you considered doing analysis using a space-time cube?
Okay. The first thing, I don't know what space-time cube means.
Okay.
That's okay.
And
Shall I elaborate on that a little bit?
Please do.
yes, please.
Please do.
So I apologize for asking that, and I wrote it kind of poorly, but you have such interesting data, and your data is both spatial and temporal. And so a space-time cube is really just the framework for an analytic engine to look at spatial and temporal patterns together, which could be the basis, particularly for dengue, looking forward for a disease surveillance system and to see outbreaks before maybe we can detect them with the human eye, to understand when you're really seeing a change point in the mean number of cases or in the standard deviation, the range of cases, things like that. So maybe it was more of a suggestion than a question. I was just curious about what kinds of different analytic techniques you used, and looking forward, you may consider something like a space-time cube.
Yes. I must add to that, because as I said, the primary data was collected by the public health inspectors with the handheld devices. In Sri Lanka, we are still have not covered that group of healthcare providers 100% by giving them procuring devices for them. So they use their own like personal devices, and the coverage is still not 100%. And as dengue was not as severe as COVID-19 situation, now we have coverage issues. And some of the things are related to the recent economic downturn. So because of that, actually we have thought about like doing, taking this as a cohort and to see the spatio-temporal, the patterns of dengue, but we have coverage issues.
Understood, thank you.
Thank you. Dr. Esti, a small request. If you can quickly pull out something on this, the space-time cube, if you could put it on the chat, maybe Lakshita and the others would be
Yes.
able to learn it more, or you could share it with me if you can't do it right now. Thank you, Dr.
No, I will. Thank you.
Yeah.
Sure, I will.
Sure. And let's go for take one more question and then we'll move on to Dr. Nida's presentation. Dr. Susanta, you wanted to ask something?
Yes, Lakshita, regarding how the compliance of the operation level workers regarding uploading the data to the system. The other question is what are the what you have taken to maintain the sustainability of this project? That's the main question I want to ask.
Yes. So compliance was good, I would say, because when there was a national emergency during COVID time and we collected primary data through PHIs who are computer literate to a certain extent, especially when we implemented this in the Colombo district as well as in the Western province. We didn't have many problems regarding data collection. But after the COVID problem was over, we had coverage issues because then the healthcare providers started we started taking the things lightly. So that was an issue, and the political commitment and the higher level commitment was not that. We didn't have a dedicated commitment after the COVID problem was over. So those issues were there. So now the system is mainly focusing on the dengue, and it's more of a smooth sail. Okay.
Yeah, thank you.
And there are coverage issues, and we are managing case by case.
Thank you. Thank you so much, Dr. Lakshita. Your talk has been very thought-provoking and you have more questions, but unfortunately we can't answer them, but maybe you could use the chat box to the two
Yes.
questions that Dr. Naini has asked, and
Yes,
then Dr. ST is typing in valuable information about space-time cube. So the whole purpose of the journal as well as this symposium is to share, because these are learning curves that occur during pandemic, disasters and emergencies, and by sharing we can use them for the next disaster emergency. Thank you once again, Dr. Lakshita. And catching on from what Brian Walker mentioned in his interpretation of the slide, he mentioned about polio. And we are going back to polio in the next presentation. And I have the great honor of inviting Dr. Nida Ali. She is a fellow at the Task Force for Global Health, Atlanta, Georgia, USA. She's originally from Pakistan, and she will be talking to us on Pakistan, walking the last mile for eradicating polio. We are stumbling. Yeah, so it's a perspective paper, and over to you, Nida.
Thank you, Novel, and it's absolute pleasure to be here. I'm going to say that it's hard to follow Estee and Lakshita after their wonderful presentations. My article is originally a perspective and opinion piece, but it's largely derived from the fact that community resilience, the smallest unit of it, is the resilience of health workers who are going on the front line, door to door, vaccinating people. And when we are talking about things and gaps in high-level meetings, we tend to ignore that sometimes. And, this is the thing that we ultimately have to return to if we want to eradicate a disease. And I'm going to share my screen now. Yeah, so can everybody see the screen?
Yes, and please go to full screen.
Yeah. All right, there it is. So I'm really happy to be here at this launch symposium and support Novel, whom I met in the US during my time at Emory. And Novel is a very bright mind with a very good sense of humor. Thank you for inviting me for this, Novel.
Thank you, Nida.
So here's the disclaimer that all the opinions and all the views, they are solely my own and do not represent any organization that I have worked with in past or I'm working with in the present, because I have worked with Pakistan Polio Eradication Program for 5 years. So this comes from very in-depth feelings that I have for the program, because it's still like my baby and I have, it's very, very close to my heart. So this slide represents the pictures of polio that we have forgotten in the current era because we don't see them anymore that commonly. So on the right, we see that slab from a prehistoric era from Egypt. And we can see that the person has his right leg atrophied and he's carrying a stick as a brace. So this looks like a classical case of polio with single limb paralysis. Now, on the other side, we see a girl child with braces, and this photo is from 80s. And, we don't see children like this anymore because obviously polio has been eradicated from most parts of the world. And also to mention here that the polio virus that I'm going to be talking about in this presentation is just wild polio virus, which is endemic in 2 countries only, and not the vaccine-derived polio virus, which has taken the world by storm now. So this is a picture from the 50s where people suffering from polio are in iron lungs, and they are unfortunately going to spend the rest of their lives in the iron lungs because bulbar polio paralyzes respiratory muscles. And this is a picture of a mother in the iron lung and her child by her side. So we don't get to see these kind of pictures anymore because of these 2 gentlemen, Sabin and Salk, who came up with injectable and oral polio vaccines in the 50s. And this revolutionized the whole scene of polio in the world. Now, if you see this map, this is from 1988, and there were 125 endemic countries at that point. So people ask, what progress have we made by now? And this is what the map is like now in 2022. We only have 2 endemic countries, Pakistan and Afghanistan. So this is what the wild poliovirus case count is, where we are at currently. In 2022, we have 27 cases in contrast to 2021, where we had only 6. So over the course of time, from 2017 to 2022, we can see that the polio eradication progress has been fluctuating, but there was a lot of progress that was made in 2021. But then again, in 2022, we are still seeing the active outbreaks going on in the endemic countries, as well as a massive outbreak going on in Mozambique. So my perspective article actually revolves around the gaps that we find in the field on the front line. Like Lakshita talked about, this political commitment, which is very important for any health program. I mean, for polio, we have that with prime ministers and chief ministers chairing the meetings themselves. I mean, political commitment is there, the funding is there. So what is that factor that makes us stumble and makes us, prevents us from having that final push for eradication? Because we know the virus is very smart, and as long as we have virus in one country, all the other countries are vulnerable to it. And we know the virus travels without any respect for borders, and it has, fecal-oral route of transmission, and most of the cases of polio infection are asymptomatic, so it becomes hard. So while looking at the gaps, I do not want to undermine our frontline heroes in any way, because these are the people who made this progress over the years. These are exactly the people who brought the number of endemic countries down from 125 to 2 countries now. So first, I would want to acknowledge our heroes. So some people may like this picture, some may not, but to us, the donors and funders are heroes. Despite the polio eradication taking so long, there are a few people who are now still interested in funding the program. Some donors are getting tired. Now they are questioning, pulling out, but there are some who are there with perseverance and, with the feeling that this is going to be eradicated one day. So these people who are still funding the programs are our heroes. Now this woman see their surroundings, they are dirty surroundings, and notice the way this woman is dressed. It's a conservative environment where she has to dress a certain way to move in the field, but she's still moving in the field with the vaccine carrier in one hand, protecting herself with the mask, and still managing to vaccinate children. Now, this father who opens the door for these teams whenever they come to vaccinate his child, he's also a hero because he's not refusing, he's welcoming them. And then this woman who has to cross the river to go and vaccinate children. And then these women who are, in such extreme weather situations manage to go door to door. And this is the area where going from one house to another, we have to do a considerable hike. So in such tough weather conditions, they still manage to vaccinate the children. So they are the heroes. So now we talk about the hard final push and why we are stumbling. So there are some problems that are still there on the front line. And in my perspective article, I actually speak about my experience from an outbreak response mission that we did for outbreak investigation and response in the northern part of KP. There was the active outbreak going on there at that time. And let me tell you a story, which is also very close to my heart. We were investigating in the field and I came across a mother who had so many children, and she was at the bank of the river washing clothes without any soap, by the way. And her children were in the environment where there was open defecation, open urination, and they had no running water at home. So they had kind of no concept of washing their hands after defecation. And I wanted to, listen from her, what her perspectives are about vaccinating children. So I went up to her, with the intent of striking up a nice conversation. And what I realized is that she doesn't care about vaccinating her children for polio. She didn't care about, protecting her children from the disease that they have not had yet. Because what she was actually really worried about was what she's going to feed her children next. So these are the priorities of these parents. How can they care about vaccination when they don't have a decent meal to eat? So these are the conditions that these children lived in the northern KP, and we can see that this environment is not just very friendly for polio transmission, but all the other kinds of diseases as well. For example, dengue with this open water and cholera. And again, like I said, the priorities. The children have to work really hard, so many hours to make, a decent meal for their family. And, in this situation, how can we, bring the communities together to fight against a disease when their priorities are, shelter and food? So this is the picture from that field, and I put it here because this was a very good example of, I was completely new to that area, and these were the children in the field who were actually serving as my guide and my translators. So this is the picture. This is one of the gap that we identified during that outbreak response mission, that most of the frontline field workers were males. And because that area was very conservative, they were not welcomed by the families, and women were reluctant to open doors for them. And me being a female, I had very easy access inside the households. So this was one of the gaps. And when initially I started meeting with frontline workers, I realized that, I was the only woman in the room. So this also makes it hard, but the health workers at that point, the female health workers had a very straightforward excuse that, the culture doesn't allow them to move from door to door. But my article actually is about how we managed to overcome that problem, how we pulled out women in the health systems, and we convinced them to go from door to door and vaccinate children. So this is a photo from after my meeting with the female health workers. Female health workers were very reluctant to come to one place for a meeting, but when I called for a meeting, they were responsive, and they came to see me as some kind of foreigner who was there, and they wanted to know what's this new thing that I brought. But we just had a very casual heart-to-heart discussion, and I just very gently, in a very passive manner, convinced them to go in the field. And let me tell you, during that subsequent campaign, there was a record number of female workers who showed up in the field, although it was still not 100%, but as we can see in this picture, they all still took a pledge to work at the front line. And this is a picture from the recent floods. And, we have our health workers still going in the fields despite all the challenges, exposing themselves to all the diseases and unsanitary conditions, but they are still working. So yes, there are gaps at the front line, but by no means I want to undermine the efforts that have been there by our frontline workers who are heroes, who are underpaid, but who still manage to, overcome all these barriers and still vaccinate children, because that is the ultimate unit of eradication. How many children we vaccinate effectively, maintaining the cold chain, maintaining the sanitary conditions, and, keeping the record. You can see in this woman's hand, we have a vaccine carrier, a plastic bag that has chalks for door marking and pens, and she's also carrying the paperwork. This is not an easy thing to do in the field. So I just want everybody to feel very empathetic before we start criticizing them, because we tend to do that as monitors. So I'm going to keep it very short, and for the details, you can, of course, read the articles, and I'm going to stop at this point in the interest of time. And I want to thank everybody for listening.
Thank you so much, Nida. So, I mean, it's a very touchy article, and for academics, it has so much qualitative data, but the information you convey to us and the emotions you convey to us, they are really, really strong. And these are exactly the things that we need to touch if we want to make our health systems resilient. So thank you very much for taking the courage to write this up, Nida. And I'm sure we have a lot of questions in the audience. Please go and please ask questions if you have any for Dr. Nida.
I think there are none at this point, but I would also want to mention the VDPV a bit, because we talk about it like it's polio. It's different from wild polio, but we still call it polio because it manages to paralyze children. It is transmitted in the same way. It is equally virulent and equally wild, but emergence of vaccine-derived poliovirus is in itself the indication of gaps and weaknesses in the health systems and the mass vaccination status. So these are the only basics that we have: vaccination and detection. These are the two things that ensure eradication of any diseases. And for that, we need resilience from the frontline health workers and for communities. And I know this is what you always spoke about during the year novel, the community resilience.
Exactly. Thank you. Thank you so much. And also, health systems have to acknowledge and appreciate community as a part of their resilience. The communities should be a legitimate part. It's not a kind of something that the health systems grants to the community that they are involved, but they are legitimate. They should be a legitimate partner. Thank you so much. Surina, you recently met some very important person with regards to polio eradication. Would you like to mention a little bit about your meeting in New York? Nida?
Yeah.
You met this, I forget this person's name, like you met some very historical figure in
I met Harvey Alter. He's a Nobel laureate who discovered hepatitis C virus. So he hasn't worked in polio, but he is a wonderful human being. And imagine how many lives he saved by discovering that one single virus, which we are, by the way, now on the verge of elimination. And there are several countries that have very successful hepatitis C elimination programs. And now we have a very simple 12-week cure to that. So imagine a person in his lifetime discovers a virus, and in his lifetime, he can see the tremendous progress that we have made. We not only came up with all the prevention techniques, we still don't have vaccine for hepatitis C, but now we have such an effective cure. So, I mean, that was inspirational seeing him.
Thank you. Thank you very much. Sorry, I missed the name. I messed up polio and hepatitis C. But Lakshita has a question for you. Over to you, Lakshita.
Yes, Nida. I see like you have a lot of field experience working with the communities. So introducing health behavior to the communities. So how do you appreciate the happiness that you bring or the good health behavior brings to a community before and after? Am I clear?
Yeah. For this, we have to, for health literacy purposes, we have to go outside of a little bit our job description and, actually educate them by sitting with them. For example, like when I was trying to convince a refusal, the mother was very strict about not vaccinating her children because she had so many misconceptions. I spoke to her in her language and tried to explain to her, but ultimately the thing that worked was when I showed her picture of my own son, who was 4 at that point, and told her that, look, that's my son and I vaccinate him every month. So, it's completely safe. So it was only then she was able to empathize with me and she was, convinced. So I believe that we have to sit with communities on the front line, listen to them, and then empathize with them. So so at the end of this, 15-20-minute exercise, I was really happy that I was able to vaccinate 5 children in that house. So yes, it does bring happiness. And for the woman who I found at the bank of the river, we managed to at least educate her and people around her, some other women and children, about the hand washing practices and introducing the concept of soap. But ultimately, the point is that with our polio funds, we were not able to provide, long-term supply of soaps for all of them. But still, we can do as much as we can do during our time in the field. But yes, it does bring happiness when we see the progress that is being made. And let me tell you, that mission in the North Cape was a very long mission. We stayed there for several months and we came back after we declared outbreak as closed. So this is an achievement in itself. So this brings us joy, definitely. Thank you for that question.
I think we have one, we can take probably one last question from Banura. Banura, you want to ask the question? Hi, Banura. Yeah, please.
Hi.
Sorry,
Hi,
yeah, Banura is using our same Zoom account. That's why you see my picture, but it's Banura. It's not Novil.
Yeah.
Okay, Banura.
Hi, Dr. Nada. I have a question, which is like, how would you basically understand, or what's your perspective on the understanding that health system prescriptions can be understood as reactionary sort of actions of economic and political institutions of development?
I'm not sure I was able to hear you correctly. Can you repeat the question?
Okay. How would you understand, or what's your perspective on the understanding that health system prescriptions can be understood as sort of not direct actions, but maybe indirect reactions of development prescriptions? Like, in the sense, wouldn't development prescriptions serve as an apt substitute to health system prescriptions?
Are you talking about health system restrictions?
Prescriptions, sorry.
No, prescriptions, Nida. He was telling about prescriptions, what health systems kind of tell people to do. So this is the question that he has written. Shall I read it? Dr.
Okay.
Nida, how would you understand that health system prescriptions are reactionary actions of economic and political institutions of development? How would you understand that health system prescriptions are reactionary actions of economic and political institutions of development?
Absolutely. Actually, this is covered in my article to a certain extent, because I told you that we had a force of frontline workers who were going door to door and vaccinating people. But at the same time, in the very same area, they had no decent tertiary care hospital. And if anybody had a real emergency or myocardial infarction for that matter, they had to travel 6 hours to take their loved one to the hospital by renting a vehicle. So, let me tell you, the way to get there is not a straight road. It's a very bumpy ride, and for 6 hours taking a patient at such an uncomfortable ride. And many of the patients expire on their way to the tertiary care hospital. So yes, with polio, we are providing service to your doorstep. But when it comes to essential health services, they don't have that. So their reaction and their, frustration with vaccination is kind of explained by that somehow. We have to correct the basics first. We have to give them good hygiene things. We have to provide them with toilets, with soaps, with basic health services, with primary healthcare centers, which, by the way, were there, but they had no doctors, no equipment, no facilities. So what's the point of these buildings? So I understand that the political and economic factors and institutions, they play a huge role in health behaviors in the end. So we have to correct our basics first if we want to, develop resilient communities, resilient health system, resilient health workforce. So we have to correct our basics first.
Okay, thank you, Nida. I think Barra has asked some question. I think he has elaborated it on the chat. Probably Nida could respond to that on the interest of time. Thank you so much, Nida, for your time. And now we will move on to the final presentation of our first part. And now I would like to invite Sabrina Bima Kubisa. Thank you so much, Sabrina, for submitting your paper and joining us. She is an alumna of St. Catherine University, Minnesota, USA. And Sabrina is going to talk to us today on evaluating the effectiveness of public health messaging in the immigrant and refugee community in Minnesota. So
thank you so much.
Over to you, Sabrina.
Thank you. Thank you very much for having me and for accepting my article. My name is Sabrina, as you mentioned. I am a graduate from the Global Health Program at St. Catherine University in Minnesota. And as the title of my article suggests, I was interested to see how public health professionals make sure that the messages that they create for immigrants and refugees are effective. And that's why I conducted this research. I conducted it in Minnesota specifically and the refugee population that lives here. So I'll be using the term health messaging or health message and health communication interchangeably, just to refer to any tools or material that are used to transfer messages or information to people. So here are a few points that we'll cover throughout the presentation. And first, why was this research important? This was important because effective communication, as we all know, is very essential in public health. During COVID, we experienced it firsthand. And I think every person can attest to the fact that every day there was new information that was very valuable and important for people to know. And information would be updated on a daily basis, especially at the beginning of the pandemic. Also, we know that immigrants and refugees experience many challenges within the healthcare on many levels, but when it comes to health communication, the challenges are related to lack of translation, when there is translation, there is lack of understanding and many other barriers that they face. I also conducted a previous research that identified many barriers to accessing effective health messages. And I surveyed immigrant and refugees. Some points that came included they have a lack of trust in the health messages themselves. There's a lack of trust in the people who create the messages. There are language barriers, and sometimes there's just difficulty understanding the health messages that people receive. It's also important to note that in Minnesota, there's about 10% of the population that is immigrant. And in general, we all know that evaluation is important in public health. It allows public health professionals to know how they can improve their delivery, to get feedback from their population and really understand how they can serve them better. So here's an example of principles that the World Health Organization uses to ensure that health communication was effective. Some principles that they use include accessibility. So how are people getting the messages? What platforms are they receiving the messages from? Health message has to also be actionable. Are people able to take action or change their behavior based on the health message that they receive? There's also credibility. Is this trustworthy, relevant? Is the message tailored to the population that is receiving it? And timeliness. Are people receiving the message on time? And as I mentioned, during the beginning of the pandemic, time was really very essential because and many immigrant and refugees were at a disadvantage because by the time an information was sent out, they would receive it late because there was all the process of translating it and ensuring that the translation is done well. So people from refugee and immigrant populations that speak different languages were really at a disadvantage when it comes to the timeliness of the messages that they received. And finally, understandability. Are people able to understand what the messages are about? So for my research, I wanted to see if other organizations here locally use principles that are similar to the one of the WHO or different. So I wanted to see how health professionals, how do they know that the message that they put out there are effective, especially when it comes to immigrant and refugee, because these are underprivileged communities. So I selected my participant from different organizations here, and by sending emails and just getting referrals from people. I have to say that it was quite challenging because many people did not meet the inclusion criteria, especially because some organizations did not do evaluation when it came to health messaging. And there was just a lot of people who did not have the tools or the methods to do the evaluation. I conducted interviews over Zoom and then analyze it using qualitative like content analysis. And I chose to do a qualitative research method because it allowed me to hear the perspectives and the opinions of public health professionals from themselves and understand what were their opinions on this topic of health message evaluation. So in the findings, the results that I received, there were 3 common themes that came from the interviews. There was the importance of knowing the audience, so understanding the cultural background and influences of the audience, making an emotional connection and knowing the emotional connections and preferences of people, the language and communication norms as well. The second theme said methods of health message evaluation, and these are different methods that people used for the people who fit the inclusion criteria of my research. Some people used community liaisons or direct feedback from the community, social media, or surveys and Likert scales. The third theme was challenges in the health messaging process, and there's also many challenges related to reaching the audience, translation, and also just the lack of methods and training. From the first theme, the importance of knowing the audience, like I said, many organizations serve people from different backgrounds, so really knowing those people and their cultural norms, those emotional connection. So for example, when it came to the vaccine, one example that we had was the Latinx community, and just making that connection and telling them, if you receive the vaccine, then you will be able to hug your grandparents, you will be able to see your grandparents. So knowing how much family means to this community and making that emotional connection was very effective to help people get the vaccine. Language and communication norms, just knowing what tools the populations use, what platforms they are on, how can you reach them was also very important. When it came to methods of health message evaluation, people use community liaisons who are members of the community who also work with different organizations, and they served as a bridge between the two to make sure that feedback are received back and forth. Direct community feedback, this was the preferred method for the participants because they would hear directly from the community. However, it was also very difficult, especially during the pandemic, when people were isolated and you could not really go into the community as much as before. And so that made it difficult to receive that direct feedback. Some people also use pre and post surveys and Likert scales just to know how likely are you to practice a certain behavior, for example, or asking a question before giving the health message material, and then asking the question after and see what the person has learned. And another method that they used was social media. This was very difficult because you would just look at the likes, maybe the comments and how many people shared, but it was difficult to know if a person shared a post because it was helpful or just because it was controversial. The third theme was the challenges in the health messaging process. One challenge was the difficulty to reach the target audience, not only during the pandemic, people were isolated, so people could not go easily into the community to meet people, and people relied a lot on online content. But even when people were able to go into the communities and hand out flyers, it was difficult to make sure that the person who received the flyer read it, or if they just threw it away, or even if they read it, you wouldn't know if they shared it with their family or how many people they shared it with. So it's difficult to know the extent of the people that the information reached. Another barrier was translation barrier. Although many organizations focus on translating health messages, when it came to evaluation, there was a lack of budget for translation, and many community health workers found themselves doing double or triple job to provide the health messages, the education, and then they have to translate themselves. And so that would be overwhelming for the people who, community health workers, for example. There was also a lack of evaluation methods and training. Many people that I interviewed were not trained to conduct evaluation of health messages, and they just did not have the tools. For example, like the tool that we showed from the World Health Organization, many people do not have criteria or principles to go by when evaluating the effectiveness of health messages. And like this quote suggests, a person said they were not trained in health education or evaluation, but they were just thrown into the role with COVID. I think COVID was also another situation that pushed people to really do different kind of works and multitask to make sure that people were receiving the resources they needed. So to conclude, I am sure you will read the article and get more details from the article. However, it's just important to mention that immigrants and refugees should have equitable access to health communication. And this is very important, like I mentioned before, if people who are immigrant and refugees and speak different languages can only receive messages 1 or 2 days later than other people, that puts them at a disadvantage and can be even the difference between life and death if it's information that would have saved their lives. Many health professionals that I interviewed suggested to combine methods of evaluation. For example, if you're receiving feedback from a community liaison, you can also combine it with using a pre and post survey from the community to make sure that you're getting a robust result and knowing really what the community needs. I also think that it's important to have a standardized criteria for evaluation, similar to one of the WHO, so people can have a place to refer to, and when they are getting feedback from the community, they can check probably if it was accessible, if it was credible, and they can just have a place to refer to. And I believe that future research can look at larger sample and conduct multiple interviews to just see the extent of this issue of lack of effective health messages and find more solutions on how we can improve. Lastly, I'd just like to say thank you to my readers who reviewed my article, and thank you to you all for listening to me, and I welcome any questions.
Thank you so much, Sabrina. It is such an interesting article, often a neglected group, and sometimes you even don't recognize that they exist. So now you have gone into the extent of looking at how these messages are being communicated to them and what are the best methods for doing that. Yeah, I can see a question. Thank you very much. Dr. Naini, you want to ask the question?
Thank you, Dr. Navi. Sabrina, actually, I want to say the culture. There are so many culturally and linguistically diverse population all over the world. When we implement the research among them, if can you please elaborate more recommendation to overcome the problems among culturally and linguistically diverse population, such as refugees and immigrants? Thank you.
Can you say that again, please, one more time?
Yeah, please, Dr. Naini, please, if you can speak a little bit slowly.
Oh, sorry. Actually, I want to know the recommendation for implementation, the implementation of the research among culturally and linguistically diverse populations, just like immigrants, refugees. All of the population are all over the world, especially in Australia. There are so many CALD population. I'm going to do a research on among them. So I want to know whether you have good strategies or good implementation strategies to overcome that barriers. Do you have any
Thank you for the
recommendation?
question.
Thank you.
Yeah, I can think of one or two things. I think one thing that I would like to mention is really making it a priority to include immigrants and refugees and not making it like a second choice. So whenever any intervention is being prepared for the population, making sure that refugees and immigrants are represented. So we talk about the translation, so making sure there's a team ready to do the translation, and not waiting until the intervention has started to start looking for a translator, because that puts them behind and at a disadvantage. So I would recommend really that, making sure you have those tools available, the budget for translators, and organizations have to make it a priority to ensure that this is not a conversation that will keep coming back. And when you know that something is happening, and then we start thinking about the immigrants and refugees later, but we should think about them first, like before everything, when we're thinking about everyone else. So I think making sure that that is understood, and that immigrants and refugees are not a second set of people to think about later, but they should be a priority.
Okay. Yes, Brian. Yes, thank you. Please, Brian, go ahead.
Please, may I ask Sabrina, you mentioned immigrants and refugees. But in some countries, there is a big problem with people who are disabled. And I'm very busy in Uganda with the support disabled Ugandans. Now, for reasons we don't really understand, there is a high level of people who are deaf mutes. And in fact, the chief officer of the SDU is herself a deaf mute who has just completed her university studies. But she needs sign language translators and interpreters. Have you thought about that aspect of the population? Because often their very existence is not only denied, but they're particularly deprived of education and of health resources, which could lead to recovery from diseases, for example.
That is a very good point. And it's important to think about these populations that are often underrepresented. I think my research can be extrapolated to that population as well when it comes to having access to health messages, to sign language and translation. We can even go further to accessibility of buildings and how, I was talking about making this population a priority when we are creating a health message, health communication material. Are we thinking about the people who are deaf? Are we thinking about the people who are blind and how they will access that? So I can really say that the same answer that I gave to the doctor before, making sure these people are not a second choice, not after we've created the message and then thinking about, oh, what about people who are deaf? No, we should think about them before creating the message. We should prepare those tools. And I can say the same thing when we're building a building. We should think about the people who cannot access it through stairs before building the building and making sure they have a way to access the building. So I think we need to prioritize those, those points and really, like I'll keep saying this, not making different population be a second choice and think about them after the fact, but preparing from the beginning. Yeah.
Thank you very much.
Thank you.
Thank you both of you for the question and the answer. It is very important that we are being responsive to the needs of people with different abilities. Especially they become very important in disaster situation. For example, not giving a tsunami warning, to a person who is deaf by, verbal messages could be lethal. And most of the, in Sri Lanka also we have a little bit of efforts, a lot of efforts, but very little progress. But it's good that now we are recognizing people with disabilities as important groups that need health communication. And thank you so much for focusing on this very important area.
Thank you very much.
You're welcome. With the interest of time, I would now like to move on to the second part of our presentations. But before that, I would like to turn the microphone to Tony, who is an advisor to our journal. Tony, would you like to say a few words at this point before we go on to the next section? Okay, maybe I think Donny would, we will turn to him later. So now we will straight away move on to the next part of the presentation, the next set of presentations. So I would now like to invite Dr. N.K. Velikumbura. She's a medical officer at the base hospital Balapetiya, Sri Lanka. And Dr. Velikumbura will be speaking to us on hospital preparedness for COVID-19 at a base level hospital in Galle District, Sri Lanka. Over to you, Dr. Valikumbura.
I will share my screen.
Please do.
Can you see it?
Yes, we can see. Thank you.
Okay. Good evening, everyone. I'm Dr. Nisansara Hemakumari Valikumbura. First of all, I would like to thank Dr. Noel, my teacher, for giving me this opportunity. This is where my story begins. This hospital, Balapitiya, where I did my internship. There are 3 base hospitals in Galle district, and base hospital Balapitiya is the largest among them. So I thought of doing my research in this hospital. I did this research as a requirement for my postgraduate diploma in health sector disaster management. My research topic is hospital preparedness for COVID-19 at a base level hospital in Galle district, Sri Lanka. Let's move on to the introduction. As we all know, COVID-19 is a pandemic. It's a serious pandemic we experienced during recent past. It caused by SARS coronavirus 2. It considered as a biological disaster. The biggest challenge we met during the pandemic is to maintain the safety of healthcare workers while delivering the care to the patients. A disaster is a serious disruption of the functioning of a community involving widespread human, material, economic, environmental losses, and which exceed the ability of the affected community to cope using its own resources. This is the disaster cycle. There are 3 phases: preparedness, response, and recovery. Here you all see how important preparedness is during the whole disaster cycle. In my research, I paid my attention on hospital preparedness. The hospital preparedness has 2 main components: preparedness among healthcare workers and preparedness of hospital physical structure and layout. My objective is to assess the hospital preparedness for COVID-19 at a base level hospital in Galle district, Sri Lanka. During that time, hospitals were categorized into 2 groups in Sri Lanka. One type is COVID treatment centers, the other one non-COVID treatment centers. Base hospital Balapitiya was not a COVID treatment center, and their task was to continue routine care, detect COVID patients, and transfer them to relevant institutions. Let's now move on to the methodology. It's a descriptive cross-sectional study. In base hospital Balapitiya, staff consisted of 15 consultants, 65 grade medical officers, 24 house officers, 42 residential house officers and 220 nurses. They are selected grade medical officers and nursing officers for this study. Data collection done in the first part of the February 2021. The study instrument consisted of two parts. One is self-administered questionnaire. The other one is observational checklist. The self-administered questionnaire was consisted of two components: socio-demographic data and preparedness of grade medical officers and nursing officers. Then the other part, observational checklist. It's developed using international and local guidelines, and the checklists and guidelines issued by European Centre of Disease Control and Ministry of Health, Sri Lanka. The checklist was described based on availability and unavailability of items given in the checklist. Let's move on to the results. First, socio-demographic characteristics. The response rate was 90.52. Majority were female because majority of nurses were female, so majority came as female. A majority of the participants were between 30 to 39 years of age. A study sample consisted of 62 medical officers and 196 nursing officers. The majority had more than 10 years of work experience. So majority were well-experienced staff. Preparedness of healthcare workers was assessed using awareness, essential general preventive measures, exposure to training programs, and safe practices related to PPE usage. The majority were well aware about the circulars and guidelines. Frequent hand washing practiced by majority of population, that was 96.9%. But we found majority had poor exposure to training programs in donning and offing as well as outbreak management. A considerable population was not confident in donning and offing. When comparing with general population, all the parameters were low among OPD and ETU staff. I took the OPD and ETU staff separately because they are the first contacts to the patients. So preventive measures taken from that level is more important. Let's move on to the hospital preparedness. There was absence of dedicated respiratory ward was noted. The importance of respiratory ward is to separate respiratory patients from the other patients. And if we found COVID positive cases, it's easy to send them directly for isolation facility. But here dedicated respiratory ward was absent. There was no separate area to manage unstable respiratory patients at ETU. But they had a fever corner, but that was just to examine the patients with respiratory symptoms. Body temperature screening was not available at hospital gate. Poor maintenance of social distancing at OPD was noted. Hand washing facilities was not available at the triage area, but alcohol hand rub was available. This is the triage area. They covered the nursing officer's side, separate from the patient side. And this is the fever corner at all. let's move on to the conclusions. A majority were aware on updates about guidelines, but a considerable population showed poor awareness. Majority didn't receive adequate training on donning and doffing and also outbreak management. Considerable population was not confident on donning and doffing, especially OPD and EPO staff. And we didn't see good adherence to social distancing among healthcare workers. Absence of separate area to manage unstable respiratory patients and dedicated respiratory ward were the major deficiencies noted in preparedness of hospital structure and layout. Most of these deficiencies arose due to lack of space and infrastructure facilities in the hospital because the buildings and everything, they were already established. So making room for these different areas was a little harder. So my recommendations are health education, awareness activities, and training should be conducted regularly. And make updated guidelines available on outbreak management and also donning and doffing. So then staff can revise them frequently. Improve hospital infrastructure such as hand washing facilities, dedicated respiratory ward, and well-organized isolation facilities for COVID suspected patients. So I would like to suggest. Actually, later on, they developed more facilities in the hospital, including a separate ward for COVID patients. Here the problem was we did the preparedness phase during the pandemic. So it was difficult to face the pandemic and do the preparedness simultaneously. But if we have pre-prepared for an outbreak, it would be more organized than this. So thank you.
Thank you so much, Dr. Velikumbara, for that the presentation. And this was based on your work at the hospital, and this is really what happened. So this is during a pandemic. So there's a lot of lessons that we can learn from this. I think you studied only one hospital, but that tells us a lot of stories about different hospitals, their strengths and areas for improvement. So this is a very important research, and we are talking about a hospital level preparedness and response to pandemic. Are there any questions that you want to ask any of the participants from Dr. Velikumbara? Yeah, so just to inform some of you who may not be aware, the Ministry of Health every year supports the Postgraduate Institute of Medicine to conduct a course in postgraduate diploma in health sector disaster management. So this is one of the key pillars of resilience building in the health sector, where the doctors are trained to 6 months of teaching, and then they go to a hospital and do a risk assessment, prepare, plan, and deliver a disaster drill. So this has been very useful in helping the pandemic preparedness, but we can see there are a lot of areas that we still have to work on and improve. So if there are no questions, let's congratulate Dr. Valikumbura. Thank you so much for your presentation and your paper. You can read the the paper on the journal.
Thank you, sir.
Dr. Naini, you want to elaborate on your recommendation? Little bit?
Dr. Naviri, actually, I saw health education as a recommendation. I think health education is not enough because we have to change the environment and we have to change the behavior of the healthcare staff, because I also did the same type of study during my disaster preparedness, disaster postgraduate. So I think the health promotion is more elaborative than health education. During the disaster preparedness phase, then we can have a good response phase. Thank you. Thank you, Dr. Sansala, for your
Yes.
good presentation.
Thank you.
That is very true. And that is why we have to look at a hospital as a part of a health system. And there are many aspects. So health education is one aspect, but as Dr. Naini very correctly mentioned, if the supportive environment is not there, if the healthy policies and health supporting policies are not there, it's not going to happen. So healthy settings are important. So that is very true. And that is exactly what we have to explore in the concept of health system resilience further. Thank you so much for those great questions, Dr. Naini. Okay, now shall we move on to the next presentation? We will now go to Dr. GHS Fernando. He is a senior registrar in medical administration from the Ministry of Health Sri Lanka. And he's going to speak about way forwards for curative management of COVID-19 patients in the third wave in Sri Lanka. Over to you, Dr. Fernando.
Can you see my presentation?
Yes, we can see you.
Yes, good afternoon, all of you. I am Dr. Susantha. I am a medical superintendent at Base Hospital, Udugama. Currently, I am working at Hull University Teaching Hospital in UK as a medical administration fellow. First of all, I thank to Dr. Noel and team for selecting my this article on interesting journal, and wish this journal will be a popular and important journal in the world. And especially I thank, this is a platform to present and send write the article on the health system, especially important for the medical administrators. Thank you, Dr. Noel. This article on the way forward for curative care management of COVID-19 patient in the third wave in Sri Lanka. This is actually what we have done as a Ministry of Health to face this COVID-19 third wave. The first case of COVID virus reported in Wuhan city, China in December 2019. In that, when we were in our country, we didn't think even that the same thing is happening as we saw. A lot of people were dying there, but we didn't thought it will happen to our country. But unfortunately, the first case was detected in January 27th, and this is the Chinese nation who came from the Wuhan city. Then our first COVID local case reported in 11th of March. After first case, we got the threat of having this pandemic to our country. Our Ministry of Health and the government taken many strategies, especially country was totally locked down during this period. Because of that, we were able to control this disease in the first wave, and we limited to 3,000 patients during this period. However, unfortunately, because of this virulence of this virus, we couldn't control this. Therefore, we had to face 3 waves of COVID in our country. In this first wave, we could be able to manage all the patient within 9 hospitals we nominated as COVID treatment center in the country. However, because of this high spike of patients, we were not able to control this. Therefore, we had to expand our curative care services. As a focal point in the Ministry of Health, DDG Medical Service 1, especially the leader is Dr. Lal Panapitia, with his team, with the help of other authorities in the country, develop the hospital to manage this COVID-19 patient. You can see the first wave we marked on 27th of January to October, 3rd of October 2020. In this wave, the patient were limited to 3,396. Only 13 deaths were occurred. But because of high virulency and high transmission rate, the second wave started 4th of October 2020, which was ended 14th of April 2021. In this period, this 6 months, there were 92,341 patients were reported and 591 patients were died. After that, we couldn't control the third wave because of government decided to relax the restriction, as well as our New Year festival came. People behavior was changed because of that third wave arise. You can see during within 3 months, 15th of April to 19th of July, 1,819 patients were reported, including 3,175 deaths. However, up to now, up to today, around 670,749 patients were reported in our country. Because of high virulency, high transmission rate, ministry understand the patient cannot be managed within this 9 hospital we name as the COVID management centers. Therefore, 3 levels of hospital were developed in the Ministry of Health with the help of Presidential Task Force and the Navy Commander has team and other organization. You can see the level 3, the level 1, the all asymptomatic COVID-19 positive patients were managed this level 1 hospital. These are not the hospital. Previously the training centers were converted as a COVID treatment centers by either help of Army Commander has team. These centers were affiliated to nearby government hospital. Therefore, the director or in charge of the nearby government hospital given the responsibility to manage these centers. The all resources, including human resources and the physical resources, were sent to this hospital to manage this hospital. The director sent the staff rotation basis to the centers to manage this hospital. Some private hotel were managed as an intermediate care center, level 1 care center to manage asymptomatic patients. If patient developed some symptoms, they were transferred to the level 2 or level 3 hospital. The medical officer is in charge of this hospital. There were no consultant allocated to this hospital. The level 2 hospital mean the mild to moderate symptomatic patient and patient with comorbidities were managed this hospital. These are the primary and secondary care hospital. Few primary and secondary care hospital in the government converted totally as a COVID management centers. The medical consultant were in charge of the centers. Some hospital there were a consultant, but ministry decided send consultant to this hospital to manage this secondary level hospital. The HTU facilities were developed and for the management of oxygen dependent patient in this hospital. Level 3 hospital, these are the highest qualified hospital. We had 9 hospitals. These are moderately severe severely ill patients were managed in this hospital. A few secondary or tertiary care hospitals were converted as this level 3 hospital, and ICU and especially ICU were developed this hospital. They are experienced and very expert in the medical field. The consultant were managed this hospital. You can see at the end of the second wave, ministry were able to develop a 42 second level 1 hospital which contain 10,760 bed, 37 level 2 hospital with 2,750 bed, level 3 hospital 9 including 1,550 beds, and 13 private hotel which had 1,677 bed, including the second wave we had 16,741 bed to manage COVID-19. But after third wave, you can see third wave started April 15th and the transmission rate was very high. We experienced there are more than 2,500 patients were reported per day. Sometimes it was increased to 3,000. The symptomatic patient were increased, and most of the oxygen dependent patient were increased. Therefore, the ministry understand the existing capacity were not able to manage this hospital. Therefore, the ministry has taken many decisions to control this, face this third wave. Still the movement restriction and health education was expanded, especially our provincial movement were restricted, especially the western province in our country, highly populated province. Some areas were totally locked down and during this period, and ministry decided to convert all the government hospital as a COVID management centers, and therefore some wards in each and every hospital converted as a COVID management center while continuing the normal routine work. Therefore, at some 1 or 2 wards, they converted as a COVID management centers, and more intermediate care centers were developed with the help of Army Commander and other non-organizations, and especially ICU and HCU beds. The capacity were increased. For that, ministry take an existing instrument in the country. After that, by special procurement, they purchase many instruments, especially the HCU bed, ICU bed, ventilators, non-invasive ventilators, oxygen concentrators, and oxygen plant, and then our MSD purchase many oxygen cylinders, thousands of oxygen cylinders. These are quickly within few months. Our ministry purchased all the equipment and distributed all over the country to establish HCU in our country. Then a diagnostic capacity was increased, and online training program were arranged by the medical service, director medical service, by using the expert in our country. And then sometimes patient had to wait 1-2 days at home. Therefore, integrated care, home-based care was started, and a call center were developed in the Ministry of Health with the help of our GMA. They were managed, the doctors have managed this patient until they get a place in the hospital. You can see as a result, with the third wave, the level 1 hospital, it has increased to 96 centers from 42 to 97. You can see level 2, 37 to 74 centers, 13 to 60 private hotels were increased. You can see altogether. Earlier, we had around 16 beds in the country. In the third wave, the bed strength was increased to 37,473. This was double because quick actions taken by the Ministry of Health. You can see that district distribution of our hospital. We have in Sri Lanka, we have 25 district. Each hospital develop, each district develop some COVID management centers according to their population and the presentation. The good decision taken in this third way is in the second wave, all the COVID management centers were coordinated, managed by centrally. In the third wave, all authority were delegated to our provincial health authorities, especially RDPDs. After that, they developed their centers in their district. Therefore, they could able to manage their patient in their region. In the second wave, sometimes people were transported more than 200 kilometers away from their home to manage this. But after develop this delegation of power to establish COVID center in the district level, they develop their own centers. You can see the district distribution of the COVID centers in our country. ICU, especially we had allocated in the second year 260 ICU bed. You know, in our country, still we have around 600 to 700 ICU bed for total country still now. But the country, we had allocated 204 beds for COVID patient in third wave. ICU, HU bed, you can see only we had 630. Within few months, it has increased to 10,033 HU bed to manage oxygen dependent patients. Then this is the PCR capacity was increased with the other development outcome. As a result of that, all the patients are managed under healthcare professional. You can hear some developing countries, patients were died at home without seeing a medical profession. In our country, it was not happen. Each and every patient were managed by a healthcare professions, and all the patients receive a bed in a hospital or intermediate care centers. Each and every patient will receive a bed during this period, and patient was transported to hospital as back to the home free of charge. The government, especially the Ministry of Health and the army, using the army commander and his team, all are transport freely to both places. And we conduct survey regarding the satisfaction of the these COVID management centers. More than 90% patients who treated in these COVID management centers were highly satisfied on the service given by the Ministry of Health, because we have given everything. Basic facilities were freely supplied, even clothes, foods, everything were freely given by the Ministry of Health with the help of government. This is not a one-man show. Each and every people help to come back, face this problem. Special Presidential Task Force, Special President and the Army Commander has team and tribe forces and COVID Steering Committee, Ministry of Health. Every day they get together, discuss this issue with the other official and taken quick decisions. And Health Minister, Secretary of Health, additional secretaries, DDGHS, our all DDGs and other directorates and provincial health authorities, they were very helpful. They were very actively participated and work as together to face this issue. We can't forget all the health staff, from consultant to minor employee. They were actively participated to face this issue, especially our SLMA consultant colleges and UMA and other unions. Every aspect of people, medical as health, non-health, every people were helped to face this situation. How this article was written actually what we have done, and this is a history for future administrators, how we manage this situation. That's why I wrote this as a history. Thank you.
Thank you so much. Thank you so much, Dr. Fernando, for that presentation. And it shows the amount of hard work that has gone from different sectors. We started at Presidential Task Force level, to hospitals, to DGHS, to different organizations, different sectors working together to um, give people the best possible care during the challenging times. Uh, may I ask you a question? Like, what was the role of the Disaster Preparedness and Response Division in this whole operation?
I think they were done marvelous job. You know, I also work with them. All the information is very important for the everything. All the coordination part were done during the disaster management unit. Every information were collect together and produce daily reports and sent to the especially the COVID steering committee. Every day they are made and get decision. The decision were taken by the according to the report given by the disaster management unit. They were marvelous job they have done. Yes, sometimes the hospital, if there are any issues, there are hospital, this COVID management centers, maybe physical issues, maybe human resource issues. They were mainly complained to disaster management unit. Through that disaster management unit, the information were gone to the responsible officers in the ministry. From that, the decision were taken. They have done this marvelous job. Yes. It is very, I think disaster, if we didn't have a disaster management unit in our ministry, I don't know what will happen. Yes.
Thank you. Thank you
Yes.
so much, Dr. Santa. It is very important that we learn from these pandemics and we don't reinvent the wheel next time. So that is why efforts like you have taken to put these numbers into paper and preserve it with the learning. Because sometimes when the next pandemic would be something different, but somebody can read this and probably learn, how we did this, and that is the resilience that we are talking about, why we don't have to reinvent the wheel next time. So thank you so much for taking your time, because this information is so precious, but very few people have time to sit and put it and collect it and compile. So you should be really commended for your passion for writing, and for being the inspiration of starting the journal. So thank you very much for you. And I hope we would be able to continue this journey, uh, gathering more evidence and more tools that we could use as a health system in Sri Lanka and as well in other parts of the world as well. Thank you. Now we would like to invite Professor Indika Karunatilaka, a great teacher of all of us. Thank you very much, sir, for taking time to join us. Professor Indika Karunatilaka is a professor at the Faculty of Medicine, University of Colombo, Sri Lanka. And Professor Indika would be speaking to us today about application of statistical modeling to interpret a health system crisis in Sri Lanka due to COVID-19. So this paper is published and you can read that, but let's go for some comments and observations from Professor Indika.
Thank you very much, Noel, and thank you for inviting. Yes, I think first of all, let me share a few words about the journal. I think it's a very important initiative, especially at this moment, because now when you think about publishing, for researchers, it's a huge challenge. And when it comes to researchers like countries like Sri Lanka, it's even the article processing fee and other logistics that are involved. And now all of us are aware of the current situation where Sri Lanka is facing. Are very, very important. And even then, a journal like this would be very much timely and very much countries like Sri Lanka, because most of the open source journals, there will be an article processing fee. So I think this will be for this region as well. So I thank Dr. Noel and the team for taking this very important initiative, and this would be a wonderful platform, especially facing the COVID-19 during the crisis. in a very resource constrained and also I would like to add one more experience where one paper is based on during the COVID crisis, where during the Delta wave, so many patients were coming to hospitals and the hospital system was almost on the verge of collapse. And that was in contrast to the situation in 2020, where the basic public health, the strong public health system in Sri Lanka came into play, and the control was very much optimal during early. There were certain shortcomings and some kind of lapses set in, and there were surges. I wouldn't exactly say waves because 2020 there were small clusters that were separated by time and location. But when it came to 2020 October, and later towards the early part of 2020, the time period with the Delta variant coming in, that thousands and thousands of patients are reported. And at that time, the possibility of admitting every patient was not there. Previous, the policy was if anyone was found to be positive, they will be quarantined. But at this time, it was not. So the hospitals are overflowing with patients, and then the ICUs beyond capacity, same with HDU. Situation, it was very important prioritizing. One important principle in disaster management, as you are very aware, is so that principle came into being, and that is where the National Center for Prevention of COVID-19 with the help of Sri Lanka Army and then the Ministry of Health and Sri Lanka Medical Association and WHO all came together and came out with a very innovative integrated where the Ministry of Health, there was a helpline, patient helpline, and National Center, there was a similar one, SMS system, where the patient is according to their symptoms, and then there was another one organized with Mobitel and Sri Lanka Medical Association. All these were combined into an integrated system, contact with their symptoms, and doctors should back and triage them, categorize them according to their symptoms and identify who need attention. And then the national ambulance system would be called immediately evacuated. And that was one system that has really helped to manage that crisis situation. So one paper that we'll be presenting involves some aspect of that exercise to predict the outcome of COVID. Yeah. So, I mean, in conclusion, this is a very worthwhile innovation initiative. And once again, I congratulate the team for coming out to the journal and wish you all the very best.
Thank you so much, sir. Thank you so much for your kind remarks and also all the hard work that was done in coordination, especially at the turbulent times of the pandemic. The Medical Association stepped in and the academics stepped in and facilitated many aspects that are documented and non-documented. So thank you so much for all that. And please read this interesting paper. Give me a few seconds for me to pull out the presentation that was sent by Dr. Dominic John Pillay. So John Pillay is Dr. Don Pillay is an anesthetic registrar at the Capital and Coast District Health Board in Wellington, New Zealand, and he has some Sri Lankan roots as well as some roots in the UK.
Hello, everybody. My name is Dominic John Pillay, and I'm a senior anesthetic registrar, currently usually working in Wellington, New Zealand. Apologies that I can't be with you live with you today. I'm currently working in Fiji and have limited access to good internet. I thought I'd give you a bit of background about myself before I launch into my study, just so you can understand what position I'm coming from. So I completed my high school in Sri Lanka and then developed an interest in disasters following some local experiences there. I chose to further explore this by doing a disaster management MSc and actually this article I'm about to discuss with you was submitted as part of that master's study. As an anaesthetist working in New Zealand during COVID, I experienced many drug and device shortages, and I was interested in looking at how Sri Lanka's current states can sort of offer the international healthcare community some lessons on how to deal with sort of device shortages and some of the factors involved. So there are shortages in Sri Lanka's pharmaceutical and medical device supply. These impacts have been clearly evident during our current economic crisis, but it's difficult to ascertain just the true nature of the supply shortage. There's been mixed reporting in news as well as academic publications. However, suggestions are that this shortage is significant and a widespread risk to uninterrupted drug and medical device supplies. Unfortunately, this has impacts to population health and well-being, and really is important for us to understand and build upon. These shortages can be seen in the ways that we've had to request for assistance from the international community and from our neighbors within the Asian region, either through websites, social media groups, WhatsApp messaging, and also formal discussion between our sort of government and other bodies. There seem to be multiple determinants in this creating this shortage, the most significant of which is the sequence of hazards which Sri Lanka has experienced from 2019 onwards, which include things like terrorist activity, the pandemic, and environmental disasters. This has created a compounding effect of these disaster impacts, which have basically affected our entire society in a complex manner. However, there may also be some latent vulnerabilities within the Sri Lankan healthcare system and within healthcare systems internationally, which is really important to look at and to assess how these hazards have created these effects and possibly allow us some ways to build back our systems better. One of these may be related to technological infrastructure and the integration between public organizations, as well as integration further than that. And secondly is accountability and transparency. And this is a problem for many countries and many healthcare systems. And this may be a problem here as well in terms of making sure that we're making right decisions based on sort of equity and the correct data. So there are a few arguments within the paper that you can read. One of the major arguments that I make is for digitization of platforms, which may be central to building back our systems better. Sri Lanka has already shown activity within this space in digitizing parts of the medical supply chain. And I've discussed this in the paper, but these may be extended further to sort of wider within the supply chain ecosystem, especially focusing at key bottlenecks within that system, one of which being the state pharmaceutical company. By digitizing these platforms within a whole system environment, it allows for better integration between these public organizations which are involved in getting the right drug to the patient, this being sort of pharmaceutical agencies, regulatory agencies, as well as the Ministry of Health and hospitals. It also allows for better private institution integration, if that's appropriate, indeed sort of local pharmaceutical manufacturers, as well as integration with civil society or indeed with international assistance when so required. These digital platforms, if they have sort of transparency of data and accuracy, they allow for a true situational awareness in the whole system, allowing these sort of very different actors who are key parts of all of this within the whole supply chain to have a shared mental model of where the problem is or where the challenges are and how do we come about them. And clearly this digitization allows us better accountability, allows things to be audited better, and I think raises the standard on and how we act within this space. Some of the limitations of my research I think is really important to consider. One is the major one is my own personal context. Although being a Sri Lankan, I don't work clinically in Sri Lanka and I don't work in a research capacity in a Sri Lankan setting. So my knowledge is limited and I have limited access to information despite knowing, despite any collaboration there. So it's really difficult to find primary data, especially for me. I've had to rely on some secondary reporting as well as news reporting, which includes introduces biases into any analysis that I've made. But it's also important to consider whether this difficulty with finding this primary data and understanding the true nature of our system is not just purely limited to me, and actually might be sort of a wider problem. And this could be possibly an opportunity for improving our healthcare resilience in the future. I'd like to sort of commend one of our colleagues, Dr. Vijay Registrar in Medical Administration, for his excellent paper in 2020, which looked at issues with drug availability and how to improve this in Sri Lanka, and sort of talks about the issues that I'm sort of find within my research of understanding exactly estimates and procurements and how this is sort of quite varied in practice within different hospitals, and it's difficult to know exactly how much drugs are used or are needed. He also comments that his research shows that there's a lead time of 11 to 14 months between an order being placed and being delivered for medication within Sri Lanka. So this is quite a long time, and I guess becomes concerning when we consider what are the actual current shortages? What do these current shortages reflect? Do they reflect a historical state of our system, or actually do they reflect current problems that we're experiencing? And if they're a historical state, well, what does this mean for our future in terms of recovery if we're experiencing these current problems because of issues 11 to 14 months ago? So I think it's really important we consider that. A huge limitation is the fact that this issues in healthcare and pharmaceuticals within the country, it's a dynamic issue. It's complex with a variety of hazards which we've discussed. And it's also varied throughout the country with different smaller local or regional institutions having different ways of working. So to make comments about this as a whole is very difficult in this environment. So these are more of an educated analysis rather than sort of basic research based on primary data. But yeah, I hope you enjoyed reading. Thank you very much. Firstly, congratulations and thank you to the publishers of this journal. Health system resilience is a highly topical and really important field, and it's an honor to be contributing to knowledge within this field, and thank you for providing a space for researchers to do this. Congratulations to other authors for supporting our advancement of knowledge, and it's a real honor to be here with you in this paper and in this journal, and I really look forward to reading your articles soon. As a Sri Lankan, I really want to express my gratitude to all those who are providing improving health and well-being in Sri Lanka during these difficult times. I'm just so grateful that you can continue to provide sort of high standards of care despite the face of many challenges, and I really hope to learn much from your efforts. And finally, thank you to everyone else for their time and interest. I really look forward to sharing more with you as we all try to improve health systems and well-being in different contexts. So thank you very much.
I would like to invite Donny Woodyard. If you are there, Donny, are you there? Donny? Yes.
Yes,
yeah,
hi.
Yeah, Donny. Yeah. So thank you so much for joining us, Donny. We are connecting after so many years, but we were in contact. So we met in Manic Farm during the crisis, and then we did a lot of things at the Ministry of Health, and you at a different, wearing a different hat, but catering to the same needs. So Donny Woodyard is an advisor to our journal. So he's the Chief of Emergency Medical and Trauma Services for the state of Colorado, USA. And he's the Vice Chair of the United States Interstate Commission for EMS Personnel Practice. So I would like to invite Donny to give a recap of what you have heard, and probably give a little bit of guidance on how we should proceed as a journal, but I would consult you later. But overall, especially with focus on your area of expertise on emergency medical services. Yeah. And also, I would like to invite you to share a little bit about the publication, the picture book that you recently published on your work in Sri Lanka. It would be very useful.
Well, thank you so much, Doctor, and really do appreciate your efforts and the efforts of bringing this together. I think, all great things start with an incredible vision. And it's one thing to have a vision, but oftentimes it stops at a vision. But what you've done here is you've taken a vision, you've empowered others, and now we have the vision that's coming into reality. So really a heartfelt congratulations. Thank you for steering this. I think what we see going on today is the foundation being established for a new collaborative to share experiences and efforts around resiliency. You've got a multinational approach right out of the gate that is incredible to be well respected. When we talk about resiliency, as we've heard from all the presentations so far today, some of the themes that continue through that is the fact of when our health systems that are engineered to deal with everyday matters of health, our systems are tuned and engineered to deal with, our normal quote situations. But when that is disrupted, be it through pandemic or disaster, or in some rare situations, the combination of a complex emergency where you have disasters plus pandemics or multiple disasters on top of each other, that's when our health systems start to crumble. And I think that globally, through the pandemic, we've learned that we need some new models to deal with surge. Some of the old models dealing with surge was you look to your neighbors, you look to the hospital down the road, you look to the hospital in the next district, or you look to the next state, or even a neighboring country. But what we saw with the pandemic is it was a global nature. And so our surge capacity that we've relied upon simply was non-existent in most situations because everyone was dealing with issues of capacity. So I think as we come through this, we're going to learn a lot of new lessons. I do want to also commend all of the, especially our colleagues in Sri Lanka for coming together to publish and to write and to record your experiences. And I think that is going to also set an incredible foundation and encouragement for those to come, hopefully for more papers and more writings. A quick pivot into, you mentioned, some photo essays. That response, I think, was one of the first major eye-openers I had in really a unique medical disaster type situation that had many different people come together from many different walks of life, led through the Ministry of Health there to build hospitals to provide healthcare, not just emergent healthcare, but preventive healthcare, infectious disease healthcare, family healthcare, all in really challenging, unique situations. There were some photos and was able to publish those out. And I look upon those as a reminder of what can be done using the resources at hand when people come together for a common purpose and a common goal. And so while certainly an emotional, difficult time in many of our lives, it's also a picture of what can be when people come together with that common purpose. So with that, again, congratulations on this incredible work. I'm looking forward to working with you and your team, serving where I can as an advisor. And let's see if we can continue to encourage global participation and bring this journal into further limelight to highlight all the shared experiences for the future. Thank you.
Thank you. Thank you so much, Tony, for that kind words and trusting us on this journey. And there's so much that we had to do, and especially we are going through a crisis right now in Sri Lanka, and that is the very same time we have to really focus on resilience, because we have never had an economic crisis like this. Everything is so expensive, and then how is the health system going to cope on the whole thing? So I think now it's time for us to wind up, but is there anything that Brian or Professor Indika or any other colleagues here would like to say, Dr. Ishanka, who has not spoken, and we have Dr. Nimali joining us from Australia, from all over the place. We're really global. So thank you so much for taking your time out. And I will open the last few minutes for any comments. Anybody, please switch on your mic and talk. We have got
Thank you very much, Dr. Noville. Actually, I raised this question in the chat, but it was not answered. I did some interviews with the frontline healthcare workers in COVID-19 management in Sri Lankan hospitals. And what I found was I really appreciate the things has done by the Ministry of Health, Disaster Preparedness Unit, and also the government. And but in the root level, especially the provincial hospitals, I found that psychological aspect, addressing the psychological impact on healthcare workers was one of the most neglected aspect because as our country is a developing country, we are focusing on the patient care. Therefore, health workers were neglected most of the time. And I would like to know what are the strategies taken to improve psychological preparedness of health workers during the COVID-19.
Yeah, thank you so much, Dr. Nimali. I'm sorry we missed your question, but I think, but let's now create the space for that. Thank you for the question, and Donnie wants to say something. Please, Donnie.
Yeah, I think, wow, what you have brought up there is so key, so important. And it's not isolated to Sri Lanka. I want to say that first. The psychological aspects, we are seeing efforts of that. One of the roles that I have here in Colorado includes the unfortunate side of the discipline and investigation of our very own medical providers. And we're seeing spikes, and I see these spikes with my colleagues definitely across the United States, spikes amongst our healthcare colleagues who are making career-ending decisions that are often related to extreme psychological stress, trauma that's not been properly diagnosed and dealt with in their own lives and their own careers. How we address that is something that I'll be very honest that we are still trying to figure out here. One of the programs that we have recently implemented is something that we're looking at our emergency health workers. And so we are trying to offer a combination of priority access to psychological care. We're trying to make that access, reduce the barriers to getting access to that care through financial paying for it and removing that barrier. We're also trying to make sure that the program is confidential and that we are providing certain levels of protection for people who voluntarily try to enter the program. And again, I'm talking about for our health workers themselves. So we are trying to encourage that. We're also trying to experiment with programs that help relieve just the general stress. And while it's going to look different in Sri Lanka versus Australia versus here in the US, some of those programs that we're looking at, we would even call them concierge services. So we've tried experimenting with concierge services. So for a healthcare worker that's putting in extra hours, staffing shortages are high, we're saying, well, can we even assist with providing, for instance, someone that's going to help find childcare for their family, or someone that's going to help identify the right, handyman to fix their home or their car. And just by trying to provide some services that relieve micro stress, we're hoping that we provide space for them to decompress and deal with their own trauma and psychological emergencies. So I say that just to summarize from the aspect that we are still trying to figure this out. We recognize there's a surge in psychological trauma amongst healthcare. We recognize that there's a need, and we are together trying different approaches to combat this for our new reality. Thank you, Naval.
Thank you. Thank you so much, Dr. Ishanka. Yes, thank you so much, Donnie. I thank you very much for being very open about this situation. So, like, I mean, health workers are not usually trained to take, I mean, they are target oriented and sometimes they're too compassionate. So sometimes their compassion kill them. So we have to really ask people to stop and take a breath and do the self-care part. In disaster management, we always try to, incorporate the self-care element as much as possible. But I totally agree with Dr. Nimali Munasingha's observation that we don't take care of ourselves enough. Uh, Dr. Ishanka, yes, please go ahead if you want to comment on that or anything special, anything else, please go ahead.
Sure. Thank you, Dr. Novel. Yes, in fact, I would like to shed light on what Dr. Nimali raised actually. So we, in fact, did a study among the nurses, but it was, I mean, a diploma level study. So it was like, limited only for one institution, but it was the major institution, which is the National Hospital of Sri Lanka, Colombo, which is the largest, a premier hospital in Sri Lanka. So we did a study on quality of life of the nurses of INJHSR, and we assessed their coping mechanisms as well. So what they had ultimately came up was like their quality of life, of course, was affected, and they were really scared of their health. But ultimately, even though they were affected overall, as overall health, but their role functions and their physical functions were not affected, because of course maybe with their they know that they are responsible for the patient or for the patient care itself. So anyway, what is the most important is the factors that were affecting their quality of life. What we found out was the work burden, in the sense mainly the number of working hours, because we all know the number of working hours of the healthcare personnel increased with the surges of COVID-19. And most of them, in fact, 39% of the nurses were working more than 12 hours per day. So that was one of the major factors that was affecting their quality of life. And of course, the stigma, they were really affected by the stigma that they had, because they were directly working with the COVID-19 patients. They claimed that they are, themselves, even their family members were affected because of the stigma related to COVID-19. And when it comes to coping mechanisms, of course, fairly about, they were coping very well, but there were about 16% of the population of this study sample, which is about 422, they were using substances to cope. But otherwise, overall, their coping mechanisms were effective. So I just wanted to say what we have done, but that is only one institution where we assess the, and also one healthcare category where we assess the, not the psychological aspect, but overall quality of life during the COVID-19 pandemic. Thank you.
Thank you so much, Dr. Ishanka, for sharing that. I think no study is too small to sharing. So please encourage your students or diplomates to publish it. And as Professor Indika mentioned, there's so much of issues that researchers face with publication cost and everything, especially right now. So we want to be very understanding of this situation. And now I would like to thank the Asia Foundation for giving this opportunity for us through Spring 2020 Change Maker Development Fund Award, a very small award, but it was a very, very powerful award, because we wanted to do, we were able to get all these articles published. The cost were very simple things, nothing about article processing. It's about getting a website, getting the digital object identifier, DOI registration and things like that. So none of the reviewers or the staff involved in that, they were not compensated. But this kind of modality is going to help, because we want the evidence to be free, the open source per se is actually not open, because you really need money to make things open. So we have to have a how can we so do that, bring the researchers with resource constraint to bring their experiences on the table. So that is what we are trying to do, and these little bits of pieces of information will definitely help. So I think we are on time now, so I don't want to take any more times. So let's wind up for today. But please keep in contact with us. Please read the journal and submit any articles, papers, and it doesn't have to be quantitative studies. A piece of work that we showcase today are from different variety. For example, Nida's story is so powerful, and it's just a story. So, but it is still evidence. It's still very important material. Please do share. And as we mentioned, it's share learning, sharing, and collaborating. So probably you could collaborate with other researchers. For example, here we collaborated, for example, Dr. ST's work at Esri and Dr. Lakshita's work. You could collaborate on something. And now we have some evidence about mental health issues of health workers. So probably Dr. Nimali could collaborate with some work that Donnie is doing in US. So we want to create a small platform, but in future we are very optimistic. We will go and advocate for agencies to come board and help us doing, for example, mental health related volume of the journal. Can somebody come and support us to do a volume, and then we'll go and reach out to researchers and get things together, put things together and getting it. So we are just starting very small, and as Dhoni mentioned, we have to start somewhere, if it otherwise we won't be able to do it until if you wait to get all the resources. So thank you so much everybody for being part of the journey. And let's keep our eyes on at the journal and what's happening, and let's be resilient. And you all are very important, because you all are trying to make health systems resilient. So thank you so much, and let's call it a day. And I would like to thank at this moment Banura Nandatilaka, who has been the editorial assistant for the work that a lot of work that went in. The Banura spent hours and hours of work editing and typesetting and getting things in order. Thank you so much, Banura. And again, I would like to thank the Asia Foundation Spring 2020 Changemaker Development Fund Award for facilitating this.